I think an argument could be made that the patient is the recipient of care, but they're not the consumer of care. In fact, from a medical oncologist perspective, from someone who was a practicing medical oncologist for 25 years, my referring doctors were consumers because that's how I stayed in business and had referrals. My payers were consumers because they were paying for care in a way that they were somewhat of an extension of an employer, and the employer was really paying for the care. I could say that there were a lot of consumers, but the consumer who was the least of the consumer, consuming the drug, but not consuming from a business perspective, was the patient. So how did we get to this point, and is it really a patient-focused evolution, or is there something different that's happening?
Well, I think a big part of it is that the cost of care has risen so very, very quickly, and we have become extremely uncomfortable with.
Absolutely.
We have become extremely uncomfortable with such a high percentage of the GDP being devoted to healthcare. We're just really uncomfortable with that, and we should be really uncomfortable with that. I think, though, that the discussion around each stakeholder having a different value construct, some stakeholders being consumers, some stakeholders not being consumers, I don't think that's particularly constructive. First of all, I'm not a patient, but I also took care of patients for a very long time, and although I do believe there may be individual differences, it's not hard for me to understand from a more global context what is important to patients. I talked to enough of them to have a pretty good idea, and there are nuances. I've worked for a payer long enough now to understand that there are certain global things that payers are interested in. Certainly, I was a physician, so I understand what physicians are interested in. And to that end, I also understand what innovators are interested in and why pharmaceutical companies are stakeholders in this space too. I actually think it's a lot more beneficial to take a step back and say, okay, we believe each of these have a slightly nuanced value construct, but there's actually a lot more in common than there is in conflict. And to rather than saying, I have primacy, that's not constructive. That's just not constructive. I think the fact of the matter is that a lot of my patients wanted to go on clinical trials not because that they were going to personally benefit, because they were going to help society. And I think a lot of patients do think about how much things cost, both in terms of the implications for their bank account and the likelihood they'll have bankruptcy, as well as just a sense of right about how much we're spending on treatments that might have marginal impact. And so I think it's come to a head now because we've developed this almost adversarial relationship between stakeholders. It's not constructive. It's not constructive.
Yeah, I'll just add real quick, and I think that's very well said. From my perspective, I think it is the siloed mentality that often persists because what you just described is actually very hard to do, right? So, Ted, when you talked about the denominator of, drug cost plus, let's look at it, total direct costs, let's look at indirect costs as well. I think oftentimes as a broader community, we gravitate towards what might be the easiest change to enact. And the fact of the matter is the whole discussion around value, the whole discussion around the number of stakeholders that are involved in defining it, it's just not easy.
I think we got here because as a society, we are using more healthcare. It's just that we're growing older, we're not as healthy as we should be, but no one politically wants to touch that at all. So what do? We focus on in essence, the demand side for healthcare services, and as you said, Mike, it's growing disproportionately in terms of GDP. So as a result, we have to say, we have to get value. And that's the answer. We have to get value. So we throw things out there, and we're throwing things out there from a policy standpoint that's actually hitting only one side of the supply-demand equation. And that's troubling to me because I think no matter what we do, we're never going to slow it down enough because we still have more and more demand for healthcare services.
Now that said, the opportunity here is that although there have been some clumsy attempts at defining it, we're going to talk about those clumsy attempts here in a minute. Yeah. There's a desire to bring a scientific method, some sort of objective way of measuring inputs. And I will say, unfortunately, not all stakeholders have been equally represented in those clumsy attempts. Hopefully that will get fixed. But the point is this, right? So we know there's a problem. We know that the path we're down is not going to lead to a solution. But the idea that we can bring some sort of intellectual honesty and scientific rigor to assessing these novel therapies, these changes in care delivery, a way of deciding, does this really make people feel better, live longer, be happier, enjoy more health? We're there now, and that's a good thing. We have not been there before.